faculty, dignitaries as speakers, and participants. We are in the fag end of our pre-platinum Jubilee CME. I think only 8 to complete their day program. And I have been telling everyone all the time that we have got 3-phase celebration, jubilation, Platinum Jubilee. The first stage is going to be on 31st August. And we are starting the second program on 13th September. That is the 75 for 75. 75 days will be representing each glorious year of the history of SCV. Today we have got the program from the Department of Radiology under the able guidance of Professor S. Parida. They have chosen very, very outstanding topic, the topic of common interest to surgeon, physician, oncologist, oncosurgeon, and so on and so forth. And the topic that is chosen is very advanced one. And I believe a lot of information will be definitely given during this deliberation, which will help us in the clinical practice of management CA breast. Now, CA breast is very important aspect of the surgeon, to the oncosurgeon, to the gynecologist, and to the oncopathology. Now, at the end of it, it is the histology which helps us. But before that, if we can prognosticate a disease, and particularly to the breast, the therapeutic strategy becomes easier. Today we have got 2 talks, one by Dr. Himanshu Mahanti from Yashoda Super Speciality Hospital and Cancer Institute, Ghaziabad. He will be speaking on digital breast tomosynthesis. When we discuss about tomosynthesis, which is a very advanced one, and contrast enhanced mammography. I myself is a surgeon, and I was during my days in surgery. A lot of things have moved. And the second speaker is one of our alumnus, Dr. Ankush Jajodia. I have been very aware that MR has made a lot of advancement in disease, categorization, staging, and prognostication. He will be speaking on ACR Bayrat's lexicon of MR. Now, since I am part of the urology and we have always been using the rats, that is the upcoming way of strategizing or continuing with risk group. How do you stratify the risk? Now, the CT scan and MRI has made a lot of difference, and we are going to hear from 2 of the experts. Now, he is from the Rajiv Gandhi Cancer Institute, where my friend, I believe, is still continuing as MD. Dr. Rawal, Sudhir Rawal, if possibly he is still there as MD of the Rajiv Gandhi Institute. I welcome you all. I believe that this deliberation is going to help us in knowledge building. Now, with these few words, I hand over to Professor HOD Radiology, Professor Sasmita Parida, to conduct the proceedings.
Good afternoon, everyone. Thank you, sir, for your nice introductions. So, on behalf of Department of Radiology, SC Medical College, hereby we extend a warm and gracious welcome to our respected Dean and Principal, sir, Professor Dr. Ratishar Hota, our distinguished speakers, and eminent radiologists, and to everyone in the medical fraternity present here in the audience. As we all know, our beloved alma mater, SC Medical College, is celebrating its Platinum Jubilee this year on eve of completing 75 glorious years. 75 glorious years in the service to humanity, which is a rich history dating back to the 19th century. It is currently not only a center for excellence for quality healthcare in the Eastern Zone, but also an institutional that has been providing the highest standard of medical education and training to the next generation of doctors. To commemorate this grand occasion, our institution has been organizing a first of its kind academic fest involving various departments. Today, on behalf of the Department of Radiodiagnosis, I take immense pleasure to invite you all to be a part of the CME organized by our department on the topic Recent Advances in Breast Imaging. So why we have chosen this topic? Because breast cancer is the most common malignancy in women and the leading cause of mortality if not detected early. When most people think of imaging modalities for breast imaging, they think of USG or mammography as the mainstay. However, the field of radiology has evolved substantially in the recent years to include multiple advanced technologies, and not only aid in diagnosis, but also play an integral part in detecting treatment strategy. We have amongst us two very eloquent dynamic speakers to enlighten us on this topic. Let me introduce the speakers. The first speaker is Dr. Himanshu Mahanti, who is a consultant radiologist at the Yashoda Super Specialty Hospital and Cancer Institute, Ghaziabad. He is a well-known name in cancer imaging with special interest in colorectal and breast cancer. He served as a former fellow in Switzerland and has been awarded the Bracco Fellowship by the European School of Radiology in pancreas and colorectal imaging in 2019. He has won numerous accolades by authoring many conference papers, educational exhibits, and case reports in various international journals, including RSNA. He will be throwing light on the topic of digital breast tomosynthesis to contrast enhanced digital mammography. How far we have come. The next speaker is Dr. Ankush Jojodia, who is a SCB alumni and presently consultant radiologist at Rajiv Gandhi Cancer Institute and Research Center. He is a radiologist with an illustrious academic career whose record comprises the gold medal in diploma radiology as well as the national president's gold medal in DNB radiology, to name a few of his prizes. He has served as a primary and corresponding author of around 60 research articles in index journals. He has been actively working as editorial board members to oncology journals of India and has also rendered his duties as peer reviewer and special content editor in various reputed forums. He will talk on SCR Byers lexicon for interpretation of MR only lesions of the breast. Now I invite Dr. Mahanti to start his topics.
Good afternoon, everyone. Thank you, ma'am, for your such a wonderful description. And am I audible, ma'am?
Yes,
yes. So I'm thankful to all the organizers and esteemed guests for giving me such an opportunity to talk on recent advancement in the breast imaging in such a great podium of SCB Medical College and Hospital. So today I will be talking like my topic will be on digital breast tomosynthesis. Just a minute, I'll say your name. I hope my slides are visible now.
It's coming, sir.
Okay, so I'll be talking on digital breast tomosynthesis to contrast enhanced mammography. How far we have come. So my objective for today's talk will be how the mammography has evolved from its primitive stage to the recent advanced stage like contrast enhanced mammography. So I'll be talking how far we have come from analog X-ray mammography imaging to digital full-field digital mammography to digital breast tomosynthesis and now contrast enhanced mammography. I'll be talking about the advantages of DBT, indications, and a few interesting cases which will be eye-opener to all of us. I'll be talking on contrast mammography, its basic physics, standard imaging protocol, and advantage, and some few case discussions. As we know,
Sorry for the interruption. Just half a minute. My request to all the speakers, because time is 20 minutes, we request to kindly complete within the time that is allotted.
okay,
Keep
sir.
on.
Okay. So evolution is what evolution. It explains what we are today. Every day, the nature are various characteristic to all the organisms on this earth to evolve. Likewise, the technology has evolved from its basic standard procedure to most advanced technology today. So if we're talking about the breast cancer and evolution of mammography, over the past years, we have seen the increase in incidences of breast cancer. Likewise, in parallel to increase in incidences of breast cancer, we have also seen in the dynamic changes in the investigation and management of breast cancers. So only way to curtail the breast cancer is early detection and the early diagnosis, proper diagnosis. With the help of adequate, appropriate and treatment, we can manage these cases. And as obviously the radiologist plays a major role in this setup. When we prepare to fight the war against the breast cancer, we obviously need mammography, conventional mammography. Digital mammography was still remains our primary weapon. However, during the process, we found there is very much technical limitations in the plain mammography or the digital mammography, as it is always accused of having low sensitivity in normal breast, as normal breast may obscure abnormality which may cause false negative cases. It also has some low specificity because the superimposed breast tissues may obscure the lesions and give some new lesions may come appear, and it will be like false positive cases. As you know about the density of the breast, ACR guidelines have definitely referred to us like ACR A, B, C, D. According to it, the fatty breast is ACR A. Some scattered fibroglandular tissue have ACR B reading, and heterogeneously dense breast is known as ACR C, and extremely dense breast is known as ACR D. So as we come from the fatty breast to most glandular tissue breast, the risk of breast cancer increases. Simultaneously, the fatty breast, we can detect the lesion easily. However, as with the fibroglandular tissue increases, there is more chance of losing the lesion. So it will be hidden in underlying the breast tissue. The challenges remain like interpretation in so challenges remain when there is younger individual dense breast parenchyma, and we have heterogeneous breast parenchyma and non-distorting, non-calcified cancers. So there is also sometimes misinterpretation happen with our radiologists. So we need some new technology which it can clearly show us the lesions and its architecture, its 3D structure. So we need new technology. As you can nicely see here, there is a dense breast. We cannot see any lesions here because there is such a dense breast. It is difficult to find any lesions. So when we do ultrasound, we found a lesion which is like oblong shape. It is longer. The height is lesser than its length, and there is a cystic space within the lesion. So it is a fibroadenoma with atypical hyperplasia, but we cannot detect it in plain mammography. The challenges of intervention also, even if it is a fatty breast, you can see there is a lesion is here. But what about the small lesion? We cannot say it is a benign lesion, it is a malignant lesion, as we cannot see clearly the margins. So when we did ultrasound, we found it is just an intramammary lymph node. So let's discuss about this 35-year lady with previous history of galactosil, now present with new onset painful of right breast. So seeing this such a dense breast, what we'll do? We will leave the case or we will ask for to come up after follow-up? No, we have to do something. Then we did ultrasound and we found there is an abscess sitting in the right breast exactly here. So we need more advanced technology to look at these findings in a dense breast. So upgrading the current mammography technique, these limitations were the driving force behind the efforts to upgrade the existing mammography technologies and introduce newer ones offering enhanced detection and diagnosis of breast cancer. So these technologies should be affordable, should be fast, and should be acceptable. So a new weapon had to be added to the diagnostic arsenal. So the 3D tomosynthesis came. It is expected to resolve many tissue overlap reading problems that are considered a major technical limitation of digital mammography. It is just like same mammography what we use, but in this case, the X-ray tubes moves in an arc across the breast. Series of low-dose images are acquired at different angles, as you can see here, and total dose is similar or slightly higher than what we use in the 2D mammography. And ultimately, what computer gives us these slices we get. So we scroll it in the workstation and we see each slices. So clinical application of 3D tomosynthesis, by using it, we can detect more number of cancers. We can use it as a screening method, and it also reduces the recall rates. Recall rates means in Western countries, they have proper mammography screening program where the technologists take the mammography, they send images to radiologists. And when radiologists feel there is an abnormality, it needs some further investigation, they call back the patient. This is called the reduced recall rates. So it can be also used for diagnosis. It increases the diagnostic confidence about benign and malignant lesions. It also reduces the unnecessary biopsies, identifies the actual tumor size. It also tells us about the multifocal and multicentric disease, which actually changes the patient management, which I will describe you in the later images. So in this breast parenchyma, it plays a major role. Let's discuss few cases here. So while I show you a 2D digital mammography, I can hardly see any lesions. I cannot make out any small lesions, any abnormal microcalcifications or anything in that. So when you approach a mammography, it should be from outside to inside. It's from left to right. It should be like always two views simultaneously, left and right craniocaudal, left and right medial lateral oblique, medial lateral oblique. Never see separate breast separately. Always see simultaneously. So let's do an tomosynthesis and see what we are seeing. Here we can see there is two well-defined oval-shaped lesions. There is another lesion in the outer quadrant. So we could not make it in the normal mammography, whereas in tomosynthesis we can see these small lesions. Another example, in such a dense breast, even an experienced radiologist tend to miss the lesion. You cannot make out what is the lesion in the right quadrant, right breast or in the left breast. Both the breasts are extremely dense. Let's do a tomosynthesis. As you can see, there is a lesion here in the outer quadrant in the left breast. So retrospectively, if you go to the previous 2D mammography, you can also see the lesion is sitting there. In ultrasound also, we found a hypoechoic lesion with spiculated margin with central microcalcification. It was a Byrad's 5 lesion. We did biopsy, it came out to be infiltrative ductal carcinoma. So let's see another example. Obviously, you can also tell that this is a scattered fibroglandular tissue. So we can also see a lesion here. At least we can see a lesion, but we cannot tell the margin is irregular, whether margin is obscured. So we'll keep it in the higher Byrad's like Byrad's 4C or Byrad's 5. Let's do a tomosynthesis and see. You can nicely see the margins. Margins are sharp, whereas you can see call it as a obscured margin or a irregular margin, but you can see it as a sharp margin, well circumscribed margin. So we can keep it as a Byrad's 3, or it can be kept as a Byrad's 4A. So unnecessary biopsies can be avoided. So it also helps in actually identifying the actual tumor size. So here with the ACR grade 2, you cannot make out where is the lesion. Even if you see there is a lesion, you cannot make out the margin. So let's see about the tomo. You can nicely see the spiculated margin. It is just anterior to the chest wall. Later on, I will tell you about the hidden zones about the breast, where you should keep your eyes always ready to see those hidden areas, so that you cannot miss any lesion. So it is a 45-year lady. Can I? So she came for breast screening in 2D mammography. We could not make out any lesion. Whereas in the 3D tomosynthesis, we are able to see a lesion with spiculated margin. These margins are called actually in the pathology desmoplastic reaction. So in the 2D mammography, such a dense breast, if the lesion tends to be obscured by this dense breast. But in QD tomosynthesis, in the slices, we can see these lesions nicely. So in my clinical practice, I keep these 5 points always ready. These are called the 5 pulse. Why has this mammogram been done? So you should have a clinical scenario, clinical history. You have this OPD card before going for a scan, so that you can make some differential diagnosis before approaching a case. Compare both breasts simultaneously, craniopodal and MLO views. Never ever miss a chance to do an ultrasound. It is such a beautiful technology. Whenever you do an ultrasound, you interact with the patient, you inspect the lesion, you palpate the lesion. So there is very less chance you will miss a lesion. Even in screening mammography, many lesions are missed. But if you do ultrasound, you may find it. Never hesitate to ask for the help you need it. Ask your colleague, ask your seniors. If you think this lesion you can see, but you can take an opinion. Never miss skin and nipple areolar region. I will now discuss about the hidden zones of the mammography. So here, this lesion is lying just anterior to the chest wall. This is also called retroglandular space. So these are the space where lesion can be easily missed. Another space is medial half of the breast, where you will tend to miss the lesions. Another line is called Milky Way. This is anterior to the pectoralis major muscle. These are the hidden zones of breast where you tend to miss the lesions. So never lose your eyes to look at these lesions. So has this 3D tomosynthesis solved all our problems in the breast imaging? So for best result, we need morphology assessment as well as functional information. But what did this tomosynthesis give us? It gave only the morphology assessment. Still, we don't have functional information. For functional information, we need a new weapon, and this is called the contrast enhanced mammography. The first contrast mammography was approved for the sale by FDA in the year 2011. Contrast enhanced mammography, it is like same plain mammography but with a different machine. What we use this normal machine, we cannot acquire the images in that machine. We need some modern machine. It is particularly called contrast enhanced mammography machine. So we use the same contrast as we use in the CT scan. It is given in the antecubital vein. After 2 minutes, we acquire the mammography images. Whereas in each exposure, the mammography takes 2 images. In the low energy image, another is the high energy images. So this low energy image is equivalent to our 2D mammography image. So you don't need to take another plain mammography separately. So whatever the low energy image, it can be represented as plain mammography. And after getting this low energy and high energy image, the computer algorithm subtracts these images and gives you the subtracted or reconstructed image, where all the parenchymal opacities are suppressed. Only the high density or the iodine uptake lesions are seen. So you can see here a lesion which takes iodine or contrast. Only these lesions are clearly seen. Other things are suppressed. So in the low energy images also, you can use it as your reference image, 2D mammography image. So what is our protocol? We give around 1.5 milliliter per kg body weight intravenously with hand injection. Then we take images at regular interval, 2 minutes, 3 minutes, 4 minutes, 5 minutes. So these images, like you can, in the 2 minutes, you can first take the normal breast. In the 3 minutes, you can take the affected breast. Also, you can interchange. There is no fixed protocol right now available. So you can interchange. Better to take affected breast in the delayed image. Let's talk about few interesting cases which are actually the eye-opener. This is a 42-year lady we presented with a non-specific breast pain. In the low energy image, actually I will tell about the low energy image equivalent to the same as we see in the 2D mammography. So low energy images, we can see there is an oval shaped lesion, hyperdense lesion. There is no skin thickening, no nipple retraction, no abnormal calcifications. When we did the contrast mammography, we could see there is only thin rim of enhancement. This is also called the eclipse sign. So it is a sign of benign lesion. There is no intralesional enhancement. The other enhancement you can see, this is actually called as the background parenchymal enhancement. But my next speaker, Dr. Ankush, probably will tell you about this. So while we did this ultrasound, we found a cystic lesion, another cystic lesion with posterior acoustic enhancement. It's a simple benign cyst. So see another companion case. In the outer quadrant, we can see an oval shaped circumscribed margin without any desplomlastic or spiculated margin. There is no skin thickening, no nipple retraction, no abnormal calcification. So it is a birate stool lesion. We wanted to know about the functional imaging. So when we did contrast enhanced mammography, we found there is only thin rim of enhancement, actually a fibroadenoma. So another 62-year-old lady came with for our screening mammography. On low energy image or 2D mammography, we found there is the calcification. The pattern was malignant. It was segmental distribution, pleomorphic microcalcifications. We did contrast enhanced mammography and we found there is an enhancement. This is non-mass like enhancement. And we did biopsy and it came out to be IDCA, infiltrative ductal carcinoma. Sorry, it came out to be a DCIS. Next, there is a 60-year female who presented with progressively enlarging breast mass. When we hear about the age group, so you should have some differential in your mind. Young age, we may find phylloides. So in the 2D mammography or the low energy images, we cannot make out which breast is abnormal. Then we did contrast enhanced mammography. We can nicely see the contrast enhancement. This is persistently enhancing, but in delayed images, we found there is washout. And after washout, see the spectacular image. It is not a single mass. It has also a satellite lesion, which was not seen earlier. So the contrast enhanced mammography showed you another lesion or multifocal lesion or multicentric lesions you can easily detect. So this 40-year-old lady came with palpable lump. She was suspected to have a cancer in the right breast. When we did low energy image or 2D mammography, we found there is a lesion, there is nipple retraction, there is skin thickening. These are all accessory findings you should keep in your mind when you see a mammography. Go from out to inside or inside to out, but keep all those things. Then when we did contrast enhanced mammography, to our utter surprise, what you see multiple lesions. This is not a single lesion. Actually, the whole management changed from lumpectomy to total mastectomy. So this is the beauty of contrast enhanced mammography. Another 32-year-old lady, she came with lumps in the both breast. In the low energy image, we could found single or two lesions, but when we did contrast enhanced mammography, we found multiple lesions. We did biopsy, but all these lesions came out to be fibroadenoma only. But few fibroadenomas show this kind of enhancement. All fibroadenomas doesn't show such a beautiful enhancement. So these fibroadenomas known as myxomatous fibroadenomas, which show us so much enhancement. Let's talk about a 50-year-old lady who come with lump with nipple discharge. So we can see a lesion here, but do we need some extra imaging? What do we want to see extra from this? Yes, we need some extra imaging because this shows you the lesion are not the single lesion. It has such a big area, such quadrants, multiple quadrants are involved. So contrast enhanced mammography is helping in our day-to-day practice. It is changing the whole management. Probably you would have planned something and now after contrast enhancement mammography, the plan has been changed. So this is a birate 5 lesion with multi-quadrant involvement. Let's see another case. 30-year-old lady came with palpable lump. Can you see anything? No, I cannot see anything with such a dense breast. I need some extra imaging, some other technology to see the lesion. And when I did contrast enhanced mammography, I found there is a lesion in the outer quadrant. So when I did ultrasound, yes, I found there is a lesion which is oblong, wider than taller. It has a cystic space. Because of this cystic space only, I did biopsy, and this lesion came out to be fibroadenoma with atypical hyperplasia. Let's discuss about this case. In 2D mammography, you can hardly make out where is the lesion. Both the breasts are dense. You cannot make out any lesion. But when you did 3D tomosynthesis, at least you can say there is a speculated margin here, an irregular mass is there, and retrospectively, when you see, you may guess there is a lesion in the 2D mammography also. And we did contrast mammography, everything is suppressed. All that background parenchyma is suppressed, only the lesion is enhanced. This is the beauty of contrast enhanced mammography. Let's discuss about this case. So can you make out any lesion? Yes, there is a small lesion because it's a fatty breast parenchyma. We can easily detect a lesion in the inner quadrant. You can see adjacent skin thickening. So after seeing this skin thickening, it makes me think whether it's an inflammatory, is the infective, or it's a malignant. So I did contrast, and after contrast, I found only thin rim enhancement. So it gives a functional imaging. So I can be double sure that it is a benign lesion, not any malignant. I did ultrasound, and the lesion showing posterior acoustic enhancements, some thickening, internal debris are there, probably it is infected cyst. So about the lesion descriptors, I think Dr. Ankush will describe more about this thing. But let me say, like focus a breast lesion smaller than 5 millimeter. It can be single or multiple. It can be unilateral, bilateral. What about the mass? It's a 3D space occupying structure. Shape, it could be round, oval, or irregular. Margin could be circumscribed or not circumscribed. An internal enhancement, it could be homogeneous, heterogeneous, it could give us a rim enhancement or dark internal septations, which are usually seen in the fibroadenomas. So about the lesions, whether it's a multifocal versus multicentric, when you should call it a multifocal lesion. If more than 2 cancer lesions in the same quadrant, we call it a multifocal lesion. And more than 2 cancer lesions located in different quadrants, we call it a multicentric lesion. Why it is so important? Because surgery plan changes from lumpectomy to mastectomy when unexpected multicentric disease is detected in contrast enhanced mammography. Let's see an example. There is a 50-year lady who come with palpable lump with nipple discharge, underwent contrast enhanced mammography. In low energy image, we can see there is the irregular mass with speculated margins, skin thickening, nipple retraction. Everything was there to fit into a BI-RADS 5 lesion. As a radiologist, I would say there is a single lesion in the outward quadrant. But I did contrast enhanced mammography. What did I found? I found multiple lesions, multicentric. There is a lesion in the other quadrant also. So multifocal, multicentric. The plan of management changes now from lumpectomy to mastectomy. This is my standard protocol for reporting a contrast enhanced mammography. I describe about the technique. I write about the patient history, prior study, if available, I compare. I also write about the last menstruation period because it gives us the idea about the background enhancement, like a contrast enhanced MRI. So I write about the BI-RADS grading, about the fatty density, about the breast. Then I write about my findings. Then ultimately assessment, whether you give it a BI-RADS 4, 5, 2, is a separate opinion you have to give. In my opinion, I need a USG guided biopsy or a stereotactic biopsy. You have to opine because they cannot make out whether this lesion should go for a USG guided biopsy or a stereotactic biopsy. So you should give your opinion, whether you need it to see it after 6 months, you need a follow-up. So always give your opinion. So the take-home message for today's topic will be digital breast tomosynthesis and contrast-enhanced digital mammography help us better localization and morphology of breast lesions. Contrast-enhanced mammography gives us functional imaging over and above your normal morphology. Multifocal and multicentric lesions discovered in digital breast tomosynthesis and contrast-enhanced mammography changes the surgery plan. Train your eyes to look for those skin thickening, nipple retractions, speculated margin. These are the signs for a dangerous sign for any malignant lesion, any suspicious lesion. So we have traveled how far? From analog image to digital 2D image. Now we have digital tomosynthesis, and in addition to that, contrast enhanced mammography. So before ending, I would like to say necessity is the mother of all invention. When we need new technology, advanced technology to sharpen our skills, the new discoveries happen. So in the field of mammography, we have now tomosynthesis and contrast enhanced mammography. We should use it whenever it is available. and running away from your problem is the race will never win. So don't run away from the mammography reporting. See it, look it, take the help from your seniors, colleagues, try to report it. So once you report it, you will feel the confidence. Then if you have this modern technologies with you, then you are full confident to report it. Thank you for your attention.
Thank you, Dr. Mahanti, for a nice presentation. This is a very informative session. And we will have question and answer session after the second speaker.
Okay, ma'am.
So now I will invite Dr. Jajodia to give his.
Very good evening. I hope I'm audible.
Yes.
And my screen?
Yes, you can start.
So very good evening. Thank you, Dr. Parida, for such a kind introduction. And this is an honor actually to be here talking on such a podium, which is actually my alma mater, SCB Medical College. And it's actually a matter of emotion as well as an honor for me, because today I'm sitting way far miles ahead from India and from my parent institution, Rajiv Gandhi Cancer Institute. I am here in Canada and now I'm affiliated to the Hamilton Health Sciences and McMaster University, where I'm currently affiliated as a clinical fellow. And also thank you, Dr. Dashteshwar Hota, Reverend Dean and Principal, for your kind introduction. And I will definitely convey all your good wishes to Dr. Rawal. And Dr. Rawal is my MD, and he has been instrumental in shaping my career and always been there for guiding me. And I would like to start my talk by first congratulating Dr. Himanshu for such an excellent talk. And both me and Dr. Himanshu, we have a training back in Rajiv Gandhi. So basically, both our talks are aimed at the same concept, to obviate unnecessary biopsies. But as opposed to one basic difference between Dr. Himanshu's talk and my talk is, Dr. Himanshu's patients are the ones who usually just come for mammography. So mammography happens at two levels, where either there is a screening mammography or is it a diagnostic mammography. So a screening mammography patient is usually the one, it is actually very scarce in India. Unfortunately, we do not have large scale cancer screening programs in parts of India, and especially, I mean, the interior parts of India. Diagnostic mammography patient is obviously the one who always will have some kind of clinical symptom or will present with some kind of sign that will alert the clinician that there is something wrong with this patient. On the contrary, my talk relies on MR only lesions of the breast. So what are these MR only lesions of the breast? These are some notorious lesions which cannot be characterized by the conventional imaging, which Dr. Himanshu was talking about, which is basically mammography, and they are not actually targetable on the routine ultrasound that has been done by either the sonologist or a highly trained targeted radiologist. So in that case, MR comes to the it just saves MR saves the day, and by looking at the MR, even a less trained radiologist will be able to characterize, as Dr. Dateshwar Hota was talking in the beginning, that some kind of prognostication. The idea of being a radiologist is you should offer as much possible clinical information and direction to the clinician that where we can go from this. So on that note, my talk will be divided basically into three parts, where the first part is towards continuous medical education for the residents, the basics, that what is ACR, the American College of Radiology BI-RADS lexicon. And the second part of my talk will be a very niche and a very new area, which is basically called the Kaiser score, which I learned after motivation from Dr. Himanshu. I went for a short course observership in the University of Vienna in Austria, where Professor Balzer, who is today the editor-in-chief of the European Journal Radiology, and his subsequently his boss, Dr. Professor Kaiser, who was a great German breast radiologist. So they devised a unique Kaiser scoring system. And I will tell you how the difference between ACR, the normal BI-RADS lexicon, and by Kaiser scoring, we arrive at different conclusions. And then I will show you the practical cases, which are from my own library, my collection, which will be very helpful to all the clinicians that have gathered here. So starting on that note, the reporting system, which we call as the lexicon, and the ACR BI-RADS reporting system, it should always, while doing an MR, one should always have the menstrual history, and it preferably should be done basically on the second week. Any ongoing hormonal therapy should be mentioned, and the history should be taken. Now, there are various other techniques of doing of MR, where there is short MR, ultra short MR, and a normal conventional MR. I'm not going to go into the details of this because that is individualized institutional protocols. And my study on this Kaiser score is, in fact, it's not touched by if we do any of these protocols. So that is one of the best things about the Kaiser scoring system. So the size of the lesion should be mentioned, yes, because MR basically has achieved a very, very good sensitivity and specificity when it comes to staging of the disease. But when I say staging of the disease, again, the patient was symptomatic, and the clinician and the radiologist, they knew, they were aware that something is wrong. They mentioned the quadrant and the clock position, definitely, because for surgery, and as Himanshu said, the difference between all multicentric and the multifocal, for targeting, whether it has to be a breast conservation surgery can be done, whether we can give much more to the patient, or we have to go for an MRM. Location and the quadrant, it is very vital. So this is a simple where I will just, for the residents, the anterior, middle, and posterior, this is how we divide in the depth. As we know that the patient, it is done with the patient lying prone on the belly, and the breasts are almost in a state of like a free fall. That is the position in which the MR is done usually in many centers. The composition is if the breast is almost entirely fatty, or it is whether some fibroglandular tissue, FGT, which is called as FGT, fibroglandular tissue parenchyma, is there. Then if the fibroglandular tissue is heterogeneous, which usually occurs in young and less than 40. So basically that's why for a fibrofatty breast tissue above 40, mammography, standardized mammogram is advised. But if there is a dense breast, if there is much of fibroglandular tissue, which occurs usually in the young or maybe at later on stages, then MR is actually very, very helpful. So as Himanshu was telling me, this background parenchymal enhancement, it has significance, and this is one of the starting points of mention of the report in a MR mammography, where either it can be minimal, as shown in the left side of the figure, that here there is minimal, we can see some streaks and just like some salt and pepper type of enhancement is there. Then there is all this tissues and the Cooper ligaments and all, they are taking up. So there is fibroglandular tissue mild. Then it comes down to even a moderate one, and this is a marked one. So basically a marked fibroglandular background parenchymal enhancement is the one which we are concerned about, because these are ominous, and as pointed out by Himanshu, any focus which is less than 5 millimeter, there are high chances even in MR, which has a sensitivity of almost up to 100%. So they might even be missed if the radiologist is not trained enough to pick them. So the symmetry of the enhancement should also be mentioned. On my left-hand side, we can see a patient of the BCS. We can definitely see between the two breasts, there is a definite asymmetrical enhancement. And here, but the asymmetry of enhancement is attributed to post-surgical changes rather than any true disease or true pathology. But here there is a true disease, which is DCIS on this breast, and we can definitely see that it is an irregular shaped mass. So the focus, which is basically a dot-like enhancement and does not represent a space-occupying lesion, because when there is a space-occupying lesion, we definitely want to call it a mass. On a non-fat set T1 images, if the fat is interspersed between the lesion, then we call it a non-mass-like enhancement. But if it is a dot-like enhancement, then we call it a focus. So focus can also be small fatty hilum, and it has persistent kinetics. So this persistent kinetics in MRI is one of the very basic features that we have learned so far, and how to characterize it. And this goes almost always in certainty of a benign lesion, except in some cases where, in my personal experience, I have seen a very ominous triple negative breast cancer. On MRI, they will be mimicking fibroadenomas, and they will also give that typical septations and persistent kinetics. And the most important feature as a radiologist, I would always say, is follow-up examinations. So as if we can categorize the patient, we can prognosticate, and we avoid an unnecessary biopsy, and we call the patient for a next examination. And if the lesion is still stable, then definitely it is a benign lesion. But focus can also be malignant when there will be washout kinetics. Washout kinetics by a rule should always be investigated further, And an attempt should be made, as pointed out earlier, that targeted focused ultrasound should be done either by an experienced radiologist or even a sonologist, and it should be biopsied. And if not possible to biopsy it on ultrasound, then what we do in our center, we can do an MR guided VAB. And malignancy increase in size to the prior examination is also a sign of malignancy. If the lesion is unstable in some fashion, then definitely it points out towards a malignancy. So these are the MIP images, extracted images, and there we can see this very well defined just focus, and this turned out to be a node. On the contrary, here we can see that in the previous image it was very well defined, but here we can see some crenulated border, and here some kind of speculation is there. And this turned out to be such a small focus, but this turned out to be an invasive carcinoma. So mass will be either the various lexicons to describe will be the shape, which is oval, round, or irregular, and the margins, which is circumscribed and non-circumscribed. When non-circumscribed, it can either be irregular or speculated. So this I will call it means a very circumscribed, good-looking mass. And here, though some mass is irregular, but still I would not want to immediately do a biopsy of this patient. This is definitely a patient which would warrant a biopsy because it is speculated, and something that the Kaiser score relies on is initially identifying these spicules radiating from the mass, which is called as the root sign. So I will gradually show you the algorithm now. The internal enhancement here is homogeneous. We can see it's very, very beautifully picking up, but here we can see there are some non-enhancing areas within the mass, and I would call this a heterogeneous internal enhancement. And these are the typical dark septations, which are in classical literature thought to be consistent with fibroadenoma. But sometimes a radiologist has an egg on his face, and this turned out to be a triple negative breast cancer. So as I said, that old films and stability over the time is a much more vital point too. Non-mass enhancement, this is basically a focal non-mass enhancement that occupies less than a quadrant. Here we can see that the fat is intersposing in between the lesions. So it can be linear also, as we can see it is reaching almost up to the NAC, which is basically the nipple areola complex. It can be segmental, where we can see this whole triangular cone-shaped area in the apex, and it suggests enhancement within and around the ducts and their branches. So such a segmental kind is basically the one where we should be very, very cautious, because it raises the possibility of extensive or multifocal breast disease in which the prognosis is bad. It may be just regional, that encompass more than one single ductal system, or multiple regions of non-mass enhancement can be seen. So if non-mass enhancement can also be very, very diffuse, and one of the worst patterns that I have seen is inflammatory breast cancer. So this is a heterogeneous just enhancement on where the background parenchymal enhancement is not there, and it is a clump to a single segment. So this is what this clump looks like, and this is a clustered ring appearance. So clustered ring appearance, usually they turned out to be inflammatory, but again they have to be followed up, and certain clinical signs and symptoms such as fever and pain, they will point out towards an inflammatory origin. This turned out to be a simple lymph node, which is just enhancing very nicely. And this turned out to be a post-operative collection, thin peripheral enhancement with no internal enhancement. So here we see the signs of post-surgery or post-radiation, where there is gross skin thickening is there. And here some clips are there which are showing some artifacts. And the associated features like all this nipple retraction, skin thickening, and a very wide segmental distribution, they increase the suspicion of malignancy. Especially nipple inversion is one of the signs, which is almost 98% sensitive with skin retraction. So this is the inflammatory cancer I was talking about, where it is a wide diffuse type of a lesion, and they have a very, very bad prognosis. There are certain fat containing lesions, which is fat necrosis. They also have to be kept in the mind, because they suppress then on the fat suppressing images, and that will help the radiologist tell the clinician just to follow up this lesion and not to go for a biopsy straight ahead. And some hematoma and nodes are there which might have atypical appearances. So this is the basic, the new concept that I was talking about, that instead of just BIRADS, which is being read out even at a departmental level by a senior resident or a junior consultant or a very, very high senior radiologist with high experience, we just tend to assign BI-RADS. Either we say that if it is safe, we just give 1, 2. If we want to be safe, we just call it a 3 category. And if we want the patient to go for a biopsy, we call it a 4 or a 5. So this is usually what happens. There are no particular signs in the ACR lexicon. So that is the definition that tells us that if this is there, then this is the score. But Kaiser flowchart, by looking at a speculated root sign and whether it is present or absent, and then on the enhancement pattern kinetics, we can arrive at certain scores. So the scoring system will be between 1 to 11. And based on this scoring system, this system has been like challenged, and it has been trialed and tested over the period of last 5 years, including I have done over 3,200 patients from my institute. So this system is evolving, and it certainly gives a advantage, as I will show now in my particular cases. So what I'm interested right now is the category 3 and 4, where 3 is usually used by the radiologist with foci with new or increase in size. So we advise a biopsy where there is increased risk factor and increased willingness for surveillance in masses. And category 4, where there is a non-mass enhancement, as I had said, clumped, segmental and linear type, or heterogeneous irregular enhancement and rim enhancing mass with suspicious kinetics. So these are the 2 areas where we are particularly interested in and our focus lies. So this was a 48-year-old symptomatic female with complaints of breast discharge. And we can see that that was a dense mammography to start with, and a targeted ultrasound done by even experienced radiologist and me. We could not arrive at a particular diagnosis. And the cost of missing such a thing and just, moving away this female, saying that even if she's symptomatic, we knew it is actually criminal. So when we go ahead with the MR, so this is what we see. It reveals a non-mass type enhancement. Basically, the fat is intersposed in between the lesion. I do not see a homogeneous lesion. There is a lot of heterogeneity. So initially, a senior radiologist had assigned this lesion as BI-RADS 4. And when the senior radiologist had assigned it a BI-RADS 4, but with a negative root sign and a persistent kinetics. So again, following the Kaiser flowchart, this negative root sign and persistent kinetics will give only a final Kaiser score of 3. So as we had seen from the flowchart that a Kaiser score which is 1 to 4, you can easily avoid a biopsy. But still, since it was a tertiary cancer care institute and we just cannot send the patient away, and this was a clinical trial patient, so we did the biopsy and inflammatory pathology was proven on histology. So though the appearance was a bit suspicious, heterogeneous, ill-defined, it is a space occupying lesion definitely, but still it turned out to be inflammatory. Then another of the case where a 37-year, again, symptomatic female, she complains of breast discharge. So I'm seeing the mammogram and I'm seeing that there is some kind of skin thickening, and I wouldn't say this to be a nipple retraction, but yes, some kind of linear ductal asymmetry is there. Also on the spectralis muscle, I see a node. So what happens next when I do the MR, and the MR mammogram revealed a non-mass enhancing lesion, again initially categorized as BI-RADS 4 assessment by a senior radiologist who was blinded, but then a negative root sign. We see that there is no spicules arising, there is no irregularity, and the kinetics was persistent. We assigned again a Kaiser score of 3, and again a Kaiser score of 1 to 3 will call it to be just an observation. But again, we faced a problem on histopathology. This was triple negative breast cancer. So such a small focus, it turned out to be triple negative breast cancer on histology. So 42-year-old asymptomatic female on screening. So this is our screening program, since ours is a tertiary cancer institute, and we see some kind of asymmetry here. Targeted ultrasound couldn't show much. So again, we went for an MR mammography, and MR mammogram revealed a lesion with initial BI-RADS 4 assessment. So this is the lesion with a negative root sign and persistent kinetics. Again, a final Kaiser score 3 will be given based on the algorithm that I showed you, and apocrine hyperplasia was proven on histopathology. Another case where a 40-year-old asymptomatic female, again on screening program, she came down, and then we can see all this is just a vascular calcification, or there's some kind of heterogeneous density here. We cannot call this certainly a mass and then directly just try to biopsy it, because the ultrasound, the sonologist and the experienced radiologist, they kept on performing and it did not show anything. And one more very, very important thing between Dr. Himanshu's and my talk was from this step, I am jumping on directly to the MR step, because contrast enhanced tomosynthesis breast is not available in much parts of even in northern Delhi in India. So it is very limited to few specific centers. So we rely much on MR only. And when MR mammography was done, it revealed a lesion with initial BIRADS 3 assessment. We see that there is enhancement, which is leading up to the NEC, which is the nipple area complex. And though she was asymptomatic, she could have had a breast discharge, but she didn't have. And there is definitely a negative root sign along this linear enhancement and persistent kinetics, giving a final Kaiser score of 3. And definitely a ductal ectasia was proven on histopathology. So another 45-year-old asymptomatic on screening, we see a voluminous breast which has a lot of fatty tissue, and the radiologist gets happy on seeing such a breast. And MR mammography then revealed an initial BIRADS 4 assessment in these lesions, which are just, this one is looking suspicious, but it has a negative root sign if shown closely on a magnified view, and a persistent kinetics with a final Kaiser score of 3, and intraductal papilloma was proven on histology. But intraductal papilloma has been like a controversial entity, and I would leave up to the discretion of the senior surgeons here to decide whether to take them off, remove them off, or to just follow up the patient. Another patient, 42-year female, complains of newly noticed ear retraction of the right nipple. And we see some kind of focal asymmetry in the retroareolar region here, with some kind of skin thickening was there, and minimal nipple retraction as compared to the opposite side. So again, the ultrasound didn't show much, and MR was done, which revealed an irregular shaped lesion. As you can see, this is 1 minute, 2 minute, 6 and 7 minutes, and final persistent kinetics is there. Nowhere we can see any spicules or irregularity. So a negative root sign, Kaiser score is 3. MR guided VAB was performed, and proliferative disease was found on histopathology. Another 40-year-old symptomatic female on screening, we are tending to see that there is some kind of irregularity here. But when we go ahead, it is a simple peripherally enhancing lesion, and this turned out to be inflammatory cyst with a Kaiser score of 3. And 40-year-old female with cancer in the contralateral breast. So she has a precious breast because that breast was operated. And here we see a small nodular lesion. So this is MR guided VAB, a VAB which was done, mammography guided VAB, and we targeted the lesion. And before that, we did an MR, which revealed an irregular shaped lesion with an initial BIRADS assessment 4, but a negative root sign in persistent kinetics. And again, this was a benign proliferative nodule. So to sum it up, if we apply the Kaiser score, so MR comes as a problem solving tool, which is my main focus, and it resolves inconclusive or equivocal conventional BIRADS 3, 4, and 5 findings. It increases our diagnostic accuracy, sensitivity, and specificity. And in my case, in my study, it at least avoided at least 45 to 60% of unnecessary biopsies. So always biopsying a patient is, yes, it is essential, but in fact, we should always think about the kind of physical, mental, psychological, and even the financial trauma in a country like India, which is not supported by much by healthcare, the insurance policies. So we should always think about that factor also. So these are my references, and thank you.
Thank you, Dr. Ankush. Am I audible?
Yes, sir, you are.
Yeah. At the outset, I must thank both the speakers, and we feel very privileged and proud that such discussions have taken place in our pre-platinum Jubilee CME. At the outset, I must extend a very warm welcome. Please join us in the celebration. When are you coming back after your fellowship?
Sir, after a year.
So I don't think you'll be able to join our CME, our Platinum Jubilee. But anyway, Dr. Mahanti, you are always welcome. Please
Thank
join
you,
us. You are son of the soil. You are son of the soil. Why I am telling this? Because on the first day of the 75 or 75, that is on 13th of September, we will be felicitating all the speakers who have spoken for the department. If you are not able to come, we'll definitely post it, whatever felicitation material we have.
Thank you, sir.
Things before I always initiate the discussion. I am not a oncologist, but I'm a urologist. I am very much in agreement with you that ACR has already made all the RADs. You have told about PIRAD. We follow the PIRAD. You have told about the BIRAD, best imaging. Well, to both of you, this is for my curiosity. We have 3 diagnostic tools: ultrasound, CT, it may be plain CT or a CT, and a MR. How do you sequence this investigation? how do you advise a person to undergo which investigation? Because all three are complementary. It can always contribute something. Normally ultrasound first, then what you would like to go for? CCT or MR?
Uh, should I start, sir?
Yeah, please, Dr. Mahanti.
Yeah. So it is like two kind of things. The first thing, whether you are going for a screening process or you are going for a diagnostic purpose. Suppose a female comes to you with a palpable lump, then we need to diagnose it. Suppose a patient comes with some non-specific pains, he is telling I am more than 40 years, I need a annual screening. Then if it is for screening purpose, please send to her for mammography. This is just annual mammography. If the patient comes with a lump, you want to diagnose it, then see whether the patient is young or it's a like 50-year lady or a 40-year lady. So you can always start with ultrasound. If the lady is more than 40 years or 50 years, she is an elderly lady, so you expect a fatty breast parenchyma, you can go for mammography, because mammography picks up those microcalcification. They are the early signs of breast cancer, which are picked up in the screening process. Again, if the lady has some previous high risk category, suppose her mother, grandmother has already history of breast cancer, if she has been exposed to radiation, because usually 16 years, 18 years lady with lymphoma, you give them chemo radiation. In that case also they have in high risk category. So high risk category patients, you can ask for a screening after 35 years. When they become 35 years, they should go for annual screening. In that screening, you should ask for ultrasound or MRI, because young patient, dense breast, you may not see many of things in the plain mammography. So you could ask for a ultrasound or MRI. If the lady is young, she has previous history of radiation exposure, she has family history. Otherwise, for 40-year lady, if she is coming just for screening, just ask for a mammography. If she is complaining some palpable lump, both mammography, ultrasound, if required, plus minus, contrast enhanced mammography or MRI. That should be our protocol.
No, that is exactly what I was trying to ask. When we are not going for a screening, the patient is with a symptom.
Yes, sir.
What investigation should be in order?
Sir, I told, if the patient is young, you expect a fibroglandular tissue, more fibroglandular tissue. You may not get information from mammography. So ask first ultrasound. After ultrasound also, you should ask for a mammography, because these microcalcifications, there might be some microcalcification in other breast if it is not in the affected breast. So you also speak of those microcalcifications. So if young lady, ask for ultrasound plus mammography also.
Okay. Now, one more thing I would like to know from the other speaker, Dr. Agrawal. Well, you have, so many component of MR. For a mammography, what is used? T1, T2, what is used? And for the BIRAD, what are the components that those are used? Whether diffusion weighted image is used, spectroscopy used, what are the components that is used for the BIRADs?
That's an excellent question. Thank you for asking that. So basically, each individual institution has their own protocols, and these are a various sequences in MR. And a particular sequence in MR does not just give you a straightforward information. A radiologist combines all the sequences, and bits of information from each sequence finally adds up to the whole sum picture. But definitely I can answer that spectroscopy has no longer any use in breast study. Spectroscopy finds its use only in brain tumors and prostate cancers. And as far as diffusion weighted images are concerned, diffusion weighted images is altogether a different topic of study, and it's a different topic of interest. But for characterizing a lesion, whether we use for ACR BIRADS lexicon or if we use Kaiser score, we need a basic T1, because T1 shows the fat where we can first characterize the lesion, whether it will be a mass, non-mass. And then from T1, we can go into the post-contrast sequences, which in my institution, we do at 1 minute, 2 minutes, 6 minutes, and 7 minutes. But an ultra short sequence is also available nowadays. So based on these only T1 and post-contrast images, we can arrive at a particular Biret's category and try to prognosticate the lesion. The real role of diffusion weighted images and T2 weighted images is not there in prognosticating and arriving at a particular Biret's category as of yet.
Okay, perfect. Just information, MR spectroscopy is not much of value in prostate cancer as well.
Yes, sir. Yes, sir. Even we are arriving at that. Yes, sir.
Thank you. Now, Professor Parida, it was my curiosity I came in. Now, please look to the chat box for further questions. Professor Parida.
Chat box. Anybody, any of you want to ask any question? So there is no question in the chat box.
Then I think somebody, you can initiate some questions. Like me when I went for the questions. One more interesting thing which I would like to know. So basically all the images tell about the sensitivity of detection of a lesion to both the speakers. You know, whatever imaging you do, it is more to know the sensitivity. Now, when we have done ultrasound, you have done a CCT, and also you have done a MR. Now, what is the chance of missing a lesion?
When it comes to sensitivity, nothing beats MRI because many systematic analysis trials, they have shown almost 100% sensitivity in the hands of an experienced speaker and when he is studying an MRI. But when it comes to especially mammography, there are high chances of inter-observer variability, as well as there are high chances of making a technical error. There might be an error at the level of the technician while taking the images, and a very, very important cancer or a finding can be missed. When it comes to ultrasound, it is also operator dependent, and it depends on certain amount of skill that the sonologist or the targeted radiologist needs to acquire before particularly studying a lesion. But to answer your question, when it comes to sensitivity, nothing beats MRI, and there is very, very less inter-observer variability even in the hands of a very less experienced speaker and even in the hands of a very high experienced speaker. So in our institution, when we did this study, the residents who had joined newly and the professors, they almost gave the same Kaiser score, because if a particular score is there that if this happens, then you have to give this much score. So in such a very straightforward algorithm, chances of making error and very inter-observer variability is very less. Whereas the normal routine ACR Biret's lexicon, even when the MRI is followed, the professor who is very experienced, he might just call it, maybe it's a Biret's 2 or 3, and the less experienced radiologist just might call it a Biret's 4, which will cause nothing but more anxiety to the patient, and a Biret's 4 will definitely point towards a biopsy.
Biopsy. No, in fact, whatever.
Sir, permission, I would like to intervene here.
Yeah.
So the only negative thing about MRI is it gives many false positive cases. You will be seeing many lesions picking up contrast or many some signal intensities. So ultimately, you will land up like doing many biopsies. So that is the only negative thing about MRI. Whereas in contrast enhanced mammography, it is almost the sensitivity is almost like similar to MRI. Many studies have been proved it. So, and it costs like half of the cost of MRI. It costs around in the private setup, it is around 5,000 or 4,500. Whereas MRI, it costs around 12,000. And another thing is, if patient is claustrophobic, you can go for contrast enhanced mammography. So earlier, the contrast enhanced mammography was not available. Nowadays, it is getting popular. So we may expect these machines to come up everywhere. So it will definitely challenge the MRI breast.
Yeah, Dr. Mahanti and Dr. Ankur, to both of you, you know, for us, everything is free. So we are not giving due importance to the cost, but what we are giving importance, what can precisely say whether to go for a biopsy or not to go for a biopsy.
So then definitely in that case, I would say, as I've shown in my study, that MR, this Kaiser score, because my final conclusion was by using the Kaiser score in a large population of 3,263 patients, the study I did in my institute, I found out that retrospectively, I could have avoided biopsy in almost 45 to 60% of the cases. So to answer that question, it is definitely MRI.
Yeah, Dr. Mahanti, your take on that?
Yeah, another questions I got, I think in the chat box, is there possibility of radiation induced cancer if we expose high risk patients to contrast screening mammography? See, everyone is afraid about radiation. If I will give an example, if you take a flight from Delhi to Mumbai, you will get the background radiation from sky. This is the same radiation you get from mammography machine. So don't be afraid of this mammography radiations. It is similar to whatever we get background radiation.
And that is very correctly said. You know, radiation is not the biggest problem of a study, particularly CT study. All said and done. But again, my question remains to be answered. You know, what is the negative yield in case of MRI? And what is the negative yield in biopsy in case of a CCT?
So we are not using CCT exactly. We are using contrast enhanced mammography.
Mammography.
Or yeah.
Yeah.
So,
Okay.
So, sir, see, many benign lesions, like I showed you few cases like fibroadenomas, and some lesions also show us enhancement. We cannot predict their characteristic only on the imaging basis. We need a tissue sample. So, in that case,
Okay.
whenever
Dr. Ankush, what is the negative yield in after MRI?
Sir, it is very, very less, because almost we are talking about 100% sensitivity in cases of MRI. But to also add on to the question that you are asking, where Himanshu is definitely advocating contrast mammography, I will again stress, as I stressed in my talk, that contrast mammography is available in very, very few centers. Even in Delhi, I think we just have it in 2 centers, and Himanshu has it in his center. Our being a tertiary cancer care center, we do not have it. AIMS, they must be just starting it off, or even COVID has delayed it. Even a central institute like AIMS also doesn't have it as such regularly. They might be running some trials or for some study, but for regular purposes, just like Himanshu Center uses it, contrast mammography is not there. So when it boils down to some suspicious lesion, unequivocal findings on a mammography, the next best thing definitely to do is a targeted ultrasound, as Himanshu was also stressing, by a trained radiologist or sonologist. But if the ultrasound is not able to show us a particular lesion and a biopsy is not feasible, but still the patient is apprehensive, the clinician wants to arrive at a diagnosis, then MRI has to be done. And especially when in a setup as SCB, where the cost is not an important factor, I think nothing could be better than that, because in most of the northern parts of our private clinic and practices, the factor limiting for MRI is definitely the cost, and you know, the time appointment and the waiting line the patient has to get in. So if these factors are not there, and so I would then say that after a mammography, we should go for a targeted ultrasound and then a contrast MRI.
Professor Parida, back to you. Any more questions? We have exhausted this question now.
No, sir, no questions.
You can give observation. Anybody can give a very quick observation. Any expert observation from any participant on these two? If anybody would like to give an observation. Do we have any experience of MR breast in our institution?
There is a question, sir.
What do you have any experience? Do you have any experience of breast MR in our institution? Are we doing breast MR or not?
No, sir. No, sir, we are not doing.
Why we have not been doing, when we hear that so much of benefit is there by doing MR? Because we do our MP-MRI here for prostate CA regularly.
So we don't have breast part. We are not doing breast MRs. So there is a question in the chat box also for Dr. Jajodia, that what percentage of study in your study, what percentage of cases with Kaiser score 3 were found malignant?
Yes, ma'am. I saw that question, and thank you, Farah. And you can actually download the whole paper. It is an open access paper which was funded by my institution. And to be really honest, a very, very small percentage, like less than 5%, was found malignant in Kaiser score 3. And I understand that is a downside, but still it is very, very large incremental gain if you compare to what initially the ACR Byred's lexicon was offering. Also, there is another question by Sushil Kumar Giri, who is asking, in pregnancy, can MRI be the choice? Well, so in pregnancy, I would restrain myself from using MR because the patient is undergoing a lot of hormonal changes, and that might actually add on to the background parenchymal enhancement, which was my first slide, and that focus and some non-mass enhanced lesions, they can be missed. Though MR is non-invasive and it does not have any radiation exposure. So a common thought is there that in pregnancy it can be used, but again, a simple tool like ultrasonography would be my preference in pregnancy. So another question has come. Ultrasound for breast tutors in our institute experience for tumors. So I think this question is guided to
Possibly it is guided to Dr. Mahanti.
See, ultrasound is like a focused screening. If you get something in like palpation, or you find something in mammography, or you expect something, then you ask for ultrasound. Otherwise, screening ultrasound only for young patients or some high risk category who comes at the age of 30 or 35. Otherwise, you start with mammography, or you palpate, inspect. If you feel something is there, then ask for ultrasound. Ultrasound is always operated based. You cannot be like, you have some evidence that I have seen this lesion, I have not seen this image. So it's if operator says there is no lesion, what you will do? So better start with mammography. If you feel there is a lesion, you palpate it, then ask for ultrasound.
Any more questions?
No, sir. No question.
I think we should complete the deliberation for today. Thank you to both the speakers. But as the head of the institution, I welcome you again. Please be part of this jubilation. If physically possible, so far so good. Otherwise, our Professor H.O.D. Radiology will send you the link. Everything will be live streamed. So please participate. Thanks to both of you. Now hand over to Professor Parida.
Thank you, sir.
Yes, sir. Thank you. So both of them will be given by Dr. Sarthak Swarup, our assistant professor.
On behalf of Department of Radiodiagnosis, SCB Medical College, Kotak, I feel privileged to thank our Dean and Principal, Professor Dr. Datteswar Hota sir, for giving us the opportunity to organize this CME on the eve of Platinum Jubilee celebration of our college. I would like to thank both the speakers, Dr. Mahanti and Dr. Jajodia, for sparing their valuable time from their busy schedule and enlightening us with some of the recent advances in the MR imaging of the breast imaging. We are also thankful to all the participants and eminent radiologists and other colleagues for their patient hearing. I also, last but not the least, I would like to thank all the staffs of Department of Teleradiology, without which cooperation this CME will not be possible, and for smooth conductance of the CME.
So
Thank you.
1 minute, sir. Dr. Yasin sir is there amongst the audience. I would like to ask him if he will say something for this. So, sir, please. You want to tell something to us? Dr. Yasin sir, please unmute.
So Parida, possibly he is not able to come in.
Yes.
We can conclude.
Okay, sir. Thank you. Thank you, everybody. And thank both the speakers for the very nice presentation.